The percutaneous technique is used to insert a screw into the upper sacral segment from a supine position. Prior to undertaking this procedure, the surgeon must be familiar with the anatomy and osteology of the sacrum and its upper segment. Access. This is a percutaneous technique, so access is determined by C-arm visualization. The preoperative X-rays and CT scan are reviewed to determine the size of the upper sacral segment corridor and if the sacrum is dysmorphic. The indications are sacroiliac joint dislocations, iliac wing sacroiliac fracture dislocations, and sacral body fractures. Screw trajectory. Due to the obliquity of the sacroiliac joint, screws are inserted from posterior inferior and are directed anterior superior into the body of the upper sacrum, beneath the sloped alar cortical bone and above the nerve roots tunnel. For transiliac transsacral screws, the pathway is located anterior inferior in order to remain completely intraosseous and thereby avoid extruding through the alar cortical bone and the nerve roots tunnel. Patient and C-arm positioning, OR setup. The patient is placed in the supine position on the operating table. It is mandatory that the table is radiolucent so that intraoperative image intensification control may be used. A small radiolucent bump is placed under the sacrum to raise the pelvis slightly, to allow the soft tissue to fall away from the incision and allow access posteriorly for percutaneous placement of the iliosacral screw. The posterior pelvis must be well visualized in all views. If it is not, the percutaneous insertion of screws is not feasible. The patient is prepped and draped so that the involved side is available down to the OR table. The involved leg may be free draped to allow for traction and manipulation if a closed reduction is necessary. The sterile draped C-arm is brought in from the uninjured side and placed in the outlet position. A guide wire with a smooth or threaded tip is used. The preference is up to the surgeon. At the intersection of a line from the greater trochanter proximally and a line dropped from the anterior superior spine, the skin is perforated and the guide wire inserted down to the bone. At this point, the C-arm is tilted between the outlet and inlet to confirm the correct starting point for the guide wire. For this case, it will simulate a sacroiliac screw and be angled perpendicular to the SI joint. The C-arm confirms that the guide wire is directed correctly into the S1 body and avoids the anterior alar cortex and the posterior cortex, where it can enter the sacral canal and injure the nerve roots. In the inlet view, the anterior edge of the body of S1 should be superimposed on the anterior edge of the body of S2. The C-arm is tilted from inlet to outlet to assure the correct trajectory of the guide wire. Once the trajectory is correct, the guide wire may be drilled or hammered into place. By hammering, one has a better feel if the wire hits a cortex. If a guide wire with a threaded tip is used, it will easily advance and perforate the sacroiliac cortex and potentially injure the L5 root or perforate the artery. The position of the guide wire is confirmed on a lateral view of the sacrum. To obtain a true lateral, it is necessary to have either the hip joints or the greater sciatic notches superimposed on each other. The guide wire is positioned in the posterior half of the upper sacral segment body. Once the guide wire is correctly positioned, the screw length is determined and the screw is inserted. The screws are usually self-drilling screws, so unless the bone is extremely strong, the screw may be inserted without pre-drilling, which gives a better purchase. It is important to carefully tighten the screw to avoid intrusion of the screw head into the ilium and loss of purchase. Using a washer can avoid this. If an obturator outlet view is obtained, the posterior iliac cortex is seen, so when the screw head contacts the cortex, insertion is stopped.